But what about PDL1 and Riyaz? I'll start with you about in Europe the use of Imfinzi is gated by positive PDL1. That's not the case in the US. Is that something that you or others kind of wish was broader, or the data are not very strong for those with PDL1 negative? So I would say that at least many oncologists in the US are unenthusiastic about it. What's your take on this? And is this something that you're very, very comfortable with that restriction?
I mean, this is really a very, very interesting area, I think, and it highlights the differences in licensing, regulatory approval, and how that can influence clinician behavior. So it would be really interesting to know in the US how many oncologists give adjuvant durvalumab to PDL1 negative patients. It's not an option in Europe. It's not an option in the UK. Our approval Imfinzi, it's very much PDL1 positive. When I look at the data, in fact, before this meeting, I was just having a look at those hazard ratios again, and I walk away from that data very comfortable with it not being an option in PDL1 negative patients. I look at the data and it doesn't look like it does anything meaningful to me. But if I worked in an environment where it was approved in that setting, that would be a subliminal pressure for me to prescribe a treatment. In my heart of hearts, I may not feel it does very much, but if a patient and a family are coming up to me saying, "Hey, what are you doing? Why aren't you giving me this drug in, even though I'm PDL1 negative, it's approved." It would be a difficult conversation. So in many ways, I'm quite thankful that the EMA, the European regulatory authorities, have taken away that struggle for me and made it quite easy. But I would. Yeah.
What I think is really interesting, Narjust, I'd love your perspective as well, and Estella. I had previously had a mindset that if patients were in part of a trial, the trial is extremely positive, the approval is there, you do it. Narjust is now in Boston, and several people who are, global experts in EGFR and think about it all day long, are vociferous against giving this to patients with EGFR mutations, and my own view about low PDL1 or specifically negative PDL1 has evolved over time, seeing some of the curves that you alluded to, that the patients with negative PDL1 don't seem to benefit. And so once you get into the mindset of just because it's approved doesn't mean you should do it, and I would argue that the FDA now has an approach that is very liberal. They're not taking the responsibility. They don't mean to imply that you should do everything they approve. They just want to pass it on to the decision of the physician. So that's my sense, but that means that it's incumbent on the physician to be judicious or thoughtful about this and not reflexive that FDA approved means give it. Narjust, what's your view here? And then I'll turn to you, Estella.
I think what we all have to, see is lung cancer as a very heterogeneous disease. Like, while we compare to breast cancer, when you have hormonal receptor positive, HER2 positive, they're seen as completely different diseases.
Right.
And that's how we have to see lung cancer. It's no longer a disease of small cell and no small cell. It's at the molecular level. And even in the molecular level now, it's marrying for like ALK positive disease. We know the types of cell clones really makes a difference now. So we're getting to a level that's so granular that we need to see the disease as many different types of disease. For consolidation with Durvalumab, with EGFR positive mutations, I have a good conversation with patients. The majority of patients do not go in the consolidated therapy. But being a referred center also means that the patients go back home, and sometimes they're started therapy by their oncologist. But I have been in the position, Jack, and when one of my patients had disease progression, and it was an EGFR positive, and then you know the tumor is growing, but you have to wait for the durva to leave their body. That was the most stress that the patient and I had. Like, it was even more stressful than knowing that the cancer grew, as just waiting. Because you had the drug, she had the drug at home, and we were like, we have to wait, we have to wait, we have to wait. Right? So I put this patient through this journey, and unfortunately she had disease progression, and osimertinib was the best option, but Durvalumab was in her body, right? And there is no way to dialyze Durvalumab like we can do it with platinum-based therapy.
Yeah.
So you have to wait, and that is very stressful.
But
So
what about the PDL1 negative patients who?
so
That's a big group, and it is pretty. I think it's much more ambiguous than EGFR, where almost everybody, well, many of us are quite unenthused about including these patients for immunotherapy.
I do treat the PDL1 negatives, in part because we know the heterogeneous data of PDL1 and the sample size and bias in these patients, and we know the high, recurrence rate in stage 3A, 3B unresectable, right? We're talking about 60-75% or recurrence rate. I have a good conversation with the patients with PDL1 negative disease, and we discuss the options. But I'm most likely to treat these patients because, the recurrence rate is so high, understanding that you have to have a good conversation with the patient. So I guess the short answer is I mostly treat the patients with PDL1 with consideration Durva. It also depends on the genotype and phenotype of the patient. Some of my patients may have been heavy smokers, and they have, some histologic characteristics that show that, yeah, the immunotherapy may be for them, but this sample says that the PD-1 is negative. So like everything in oncology, there is never a straight answer, Jack. We never say, yes, this for everyone. No, it's like, depends on the patient, conversations, and we
You're
go from
always
there.
going to be right with it depends. Yeah.